Good afternoon, and I would like to thank the organizers to invite me to talk about the challenges to widespread PrEP in Europe and the social aspects of that. So as a start, I want to mention the ECDC report that figures that 500,000 men would want or need PrEP in the European Union. And the longer the delay in access for PrEP, the more HIV infections will occur among them. So the question is, how do we increase PrEP access, demand, and interest? And how do we increase provider willingness and integrate PrEP into the health center system? So I want to mention 3 points. First of all, let's get rid of the risk assessment checklist. Let me show you two examples. First one, the guidelines of the European AIDS Clinical Society, which was the first guidelines in 2015 that included PrEP. But now, in the latest version of October of this year, we can still read that PrEP should be used in adults at high risk of acquiring HIV infection when condoms are not used consistently. So the wording is still the same as 5 years ago. Also, if we look at another example, the impact trial, where you can see that the criteria are being HIV negative, have had condomless sex in the past 3 months, etc., etc. So a lot of criteria. Let me give you another example of the Glasgow conference this month where we saw a case presentation about an HIV negative man who requested PrEP, but he has a male partner who's HIV positive for more than 2 years and has an undetectable viral load. Now the question to the public, which are healthcare providers, is what do you recommend? One, no PrEP, or secondly, daily PrEP with TDF, on demand TDF, daily or on demand with TEF. And here you can see that 58%, so 6 out of 10 said no PrEP. Now, one of the physicians mentioned, well, if somebody comes to me and asks for PrEP, he will have his reasons for that. So we have to bear that in mind. It is true that we have a need to be more cost effective on PrEP, and we want to reduce the impact on the budget and limit PrEP only to MSM at highest risk. But if we talk about comprehensive HIV prevention, we could also present PrEP as an option to any sexually active MSM or transgender woman, based on whether this person feels PrEP is the prevention strategy she is able to use most effectively and consistently. And then we don't have to talk in these conversations, which most of the times is uncomfortable for the client as well for the physician. Secondly, language and messaging on high risk can be stigmatizing and can be a barrier to the uptake of PrEP. Let me give 2 examples of publication of this year from the FLUX study in Australia, which showed that the use of PrEP was associated with lower anxiety among gay men and transgender women. The other study also talked about the change in mental health and drug use among MSM in the UNPrEP study in Amsterdam. So why can't we make PrEP more attractive to potential users? And we can also focus on the benefits in addition to lowering infection risk, like talking about how PrEP can give you less anxiety and peace of mind, that you don't have to negotiate about the use of condoms with your sex partner, and it gives you more autonomy, or the fact that there is no latex barrier gives you more intimacy, or just to improve your sex life, and you don't have to think about acquiring HIV while you're having sex. And that increases also your mental health. Or be part of a bigger project of the HIV elimination, which is a strategy additionally to the U equals U. And thirdly, we should stop talking about risk compensation because it's misleading and it's not evidence-based. So there are no consistent studies that indicate increases in STIs. And I give you two examples. First of all, the 96-week results of the Discover studies, where you can see, except for the first moments, that during all weeks, the prevalence of the STIs were at the same level. Secondly, in the Spanish feasibility study, after 1 year, we could see that the condom use was lowered, and that was statistically significant, but the STIs had a little increase, but none of these increases were statistically significant. So on the other side, what we saw in the Spanish study, that there was a decrease in recreational drugs, and especially those drugs involved with chemsex. And you can see here the numbers of the baseline and week 52. You see that there was a decrease except for alcohol, and that most of those decreases were statistically significant. So, in a summary, in many places in Europe, PrEP is still not approved, and uptake is still hindered by many factors. PrEP can be beneficial to more groups of population, and to concentrate only on high risk is stigmatizing. We need to reduce barriers and therefore give PrEP a chance to be part of our society. And the bottom line would be, let people decide if PrEP is a valid tool for their HIV prevention. Thank you very much.